Welcome everybody to this evening's webinar. It is titled PKD and You, Understanding and Managing Related Health Conditions. So now let me introduce our speaker this evening. Dr. Vincent Lee is a kidney specialist based at Westmead Hospital. He has a particular interest in PKD, having contributed to clinical trials, Australia and New Zealand clinical practice guidelines, and the implementation of evidence into clinical practice. So Vincent, we're very excited to hear about that practical aspect tonight, and I'll hand over to you now. Thank you.
Great. Thanks so much, Jess, and thank you for the very kind introduction, and thank you, PKD Australia, as well, for the invite to talk to you about this very important, I suppose, challenging, but also, I think, fixable and treatable and approachable issue of the non-kidney, if you like, aspects of polycystic kidney disease. So what I'm going to be talking about tonight is a little bit of an introduction about PKD, polycystic kidney disease, as a condition. And then this will hopefully contextualize so that we can understand what I suppose we call extra-renal, or anything not to do with kidney, manifestations of polycystic kidney disease are. I'll be going through these as well as some of the symptoms that can affect people with polycystic kidney disease. And what I'm going to try to do is be a bit practical and particularly look at how someone who's got polycystic kidney disease, or one of the family members or carers or friends of someone with PKD, can help navigate the health system so that we can achieve the best possible outcome for everyone involved. So just a little bit of an introduction about polycystic kidney disease, or I'll call it PKD from now on. And I'm sure many of you will know this, that it comprises a group of chronic kidney diseases that are characterized by formation of multiple cysts in the kidney. It is a common cause of chronic kidney disease. If you look at people who either require dialysis or transplant, it comprises about 10%, 1 in 10 people who are on dialysis or have a transplant in Australia and New Zealand have polycystic kidney disease. There are two main types of polycystic kidney disease, and they're classified by the type of inheritance or genetic inheritance. Autosomal dominant polycystic kidney disease, or ADPKD, is the most common type. You might be surprised to know that the frequency is between 1 in 400 to 1 in 1,000, depending on the population that you're looking at. It's caused by a mutation in either the PKD1 or the PKD2 gene, and at least in the vast majority of cases, and mostly is inherited from a parent, although new mutations do occur. And so that 15% of people who haven't got an identified mutation, well, it may have been a new mutation that's developed. There is also the autosomal recessive form of PKD, or ARPKD, which is much less common and is associated with a much younger age of onset. So we're talking about childhood, teenagehood, whereas in ADPKD, autosomal dominant polycystic kidney disease, people develop that in their 30s, 40s, 50s, even 60s. Now, there are a small set of PKDs that are associated with syndromes such as tuberous sclerosis, or the ARCAD, or renal cysts and diabetes syndrome. They're very rare. Now, if you do have PKD, the clinician that is looking after you will, should be able to walk you through the different types and identify which particular one you might have. So this is a picture of the kidneys. So this is a CT scan, and this is just to illustrate that most people have two kidneys, and these kidneys in polycystic kidney disease comprise these cysts. Now, this is, I suppose, an early form of PKD. As PKD advances, the kidneys get a lot bigger, and there's a lot more cysts that develop. So you can see that the cysts are numerous. We're talking, tens to hundreds to thousands of cysts. and they range from very small in terms of millimeters up to, a few centimeters in size. Now, what we will talk about today is the extra-renal manifestations of PKD, but just to walk you through the context of if you have someone who has polycystic kidney disease or suspected PKD, the first thing you want to do when you see someone like this is to, first of all, do a full clinical assessment from head down to toe and look not just at the kidneys, but also everything apart from the kidneys. We want to do a holistic assessment and also look at things like, family history to try to identify, do you have PKD or not? And if so, what type? Now, if you do get diagnosed with PKD, then there are some basic management and self-care things that can be done. And we'll go through this in a bit more detail later on. There is some assessments in terms of prognosis, and I'm not going to go through that in detail today because there are other talks that PKD Australia have got on their website, and I'm sure Jess and PKD Australia can point you to those. So there's different types of imaging that can be done, and also there's obviously a big role for genetic testing. Then in terms of how you follow people up with PKD, there's management of the kidney disease itself, and there's also the trying to reduce the rate of progression of reduction of function in someone's kidney disease. So you want to reduce the growth and the size of the cysts. So there are various ways of doing that. There are targeted therapies such as tolvaptan, which many of you will have heard of. I won't unfortunately have much time to talk about tolvaptan today, but that is, certainly a key part of the management strategy. Now, unfortunately, with PKD, it can progress to what they call kidney failure, which is where the kidney function is not sufficient to keep someone well, and so then you have to think about the different types of therapy, which we call kidney replacement therapy, which could be either dialysis or transplant, and there's different pathways. There's a lot of people will go onto dialysis first and then get a kidney transplant. Some people will go directly onto a kidney transplant. And there's a lot of decision making in that particular space. And then once you're on those modalities, and there's also that post, transplant care. If you have a transplant, there's the dialysis care while you're on dialysis. Now, what we're going to talk about is these things. So I'm going to be talking about the assessment and management of pain, kidney cysts, kidney stones, liver cysts, heart manifestations, intracranial aneurysms, fertility and pregnancy, as well as psychological and social support. And I think it's really important to know that there is information for each of these at every stage, and they can be provided from various sources, which we'll get to towards the end of the talk. Okay, so let's talk about liver cysts first. So liver cysts are, obviously there's cysts in the liver. This is a CT scan of a liver. You can see here that normally the liver is this sort of white color, not this dark color. So these are cysts that can actually occupy the space within the liver. Now just here is the kidney on the left side, which also has cysts as well. So liver cysts is a very common accompaniment to, someone who's got polycystic kidney disease. So what happens when you have cysts? The cysts then occupy space within the liver, which then causes the liver to grow in size. So what does that do? Well, first of all, it can cause pressure against the diaphragm and lungs, which can cause shortness of breath and fatigue. If the kidneys are big enough, they can also do the same thing. And then people with big livers can have a sense of fullness in their abdomen. You might feel a little bit less mobile. You may feel fatigued, anxious. The liver, you might notice it on the surface of your belly, and so it may be uncomfortable for you. There may be problems with intercourse because of the size of that liver, and it can also cause mechanical back pain as well. Because the liver is big, it can press against the stomach, and therefore it can make someone not eat so well. can cause acid reflux, it can cause nausea and vomiting, and can cause weight loss because you're just not eating very well. These cysts can can become complicated, so they can become infected. They can bleed within the cyst. Sometimes the cysts do block up what they call the biliary tree, and therefore cause some functional problems with the liver. Not common, but can occur. And so, if you've got polycystic liver disease and it's getting a lot more in size, speak to your healthcare professional. Often we have people with polycystic liver disease that do go and see a specific liver specialist. Now, how do you manage it? Well, it is manageable. So I think surveillance for complications is really important, particularly for infection and for mass effects. In women, it's important to talk to your healthcare professional about the role of estrogen-based therapies. Now, that could be the oral contraceptive in premenopausal women. It could be hormone replacement therapy in postmenopausal women. We have seen that estrogen-based therapies are associated with an increase in size of the cysts. And so where possible, avoiding these types of therapies is ideal. Now, there are other therapies. If the cysts get really big, you can do what they call aspiration sclerotherapy. You can do transarterial embolization. You can fenestrate the cysts. These are all basically types of therapies that help to, if you like, either de-roof uh, uh, or pop the cyst so that they don't accumulate back. The cyst doesn't come back. But if if the liver cystic disease is causing significant problems, particularly with functional liver, then you may need to go to liver transplantation. Liver transplantation is obviously done in specialised centres. For those who are in New South Wales, RPA is the only centre that does that. It is possible to do a liver and a kidney transplant as well. So if that is something that needs to be assessed, obviously the transplant assessment team will work that out. There are also the use of somatostatin analogs. These are particular medications that come in injection form that help reduce the size of the cysts. Again, liver specialists are usually the clinicians that can advise you on the benefits and the risks of that therapy. There is some guidelines that the CARI group, so CARI is the Australian New Zealand group that has been around for about 20 years and has created guidelines for various different types of things to do with kidney health. Polycystic kidney disease and liver disease is one of those guidelines. And so, we can provide links to that later on. In fact, it's here where they provide those guidelines on how to manage polycystic liver disease. Okay, there are other abdominal issues as well to note. One is diverticular disease. So diverticular disease refers to little pockets of bowel that comes out, and usually it's in what they call the large intestine. Now, if you have diverticular disease and the little pockets of bowel become infected, then that's what's called diverticulitis, and so it can present with abdominal pain, fever, and you may need to have antibiotics to treat that. People with PKD can also develop these hernias, so a para-umbilical hernia, which is around the belly button area, or what they call inguinal or femoral hernias, which occur around the groin area. Now, these all occur because in PKD there is this problem with, if you like, the lining of tissues, basically where the collagen is, and so it's a little bit weaker than normal in people with PKD, and so you get these examples such as diverticular disease and hernias, and a lot of the other extra-renal manifestations of PKD are because of this. Hypertension is also very common. In fact, it's one of the first presenting features of polycystic kidney disease. And it's basically because the kidney cysts tend to cause compression within the vessels within the very, very small vessels within the kidney and cause elevations in hormones, renin and angiotensin. And so you can present with high blood pressure. You may not feel it, but if you measure it, then it can be elevated. And an elevated blood pressure, over 140 or 90 will be regarded as a high blood pressure. Now, it's really important to treat hypertension, and there are different ways of managing this. A dietary lifestyle management approach is really important, which will include a low salt diet, plenty of exercise, plenty of fluids, but also medications might be required. And these are medications that block the renin-angiotensin-aldosterone system. You may have heard of some of these medications like irbesartan, perindopril. There's a whole lot of them. So they're very useful and can be. And what I think is important is that trying to control the blood pressure in people with PKD actually helps reduce the risk of kidney function decline in PKD. So as a cornerstone of management, if you want to reduce your chances of kidney failure later on, you need to get your blood pressure well controlled. Now, vascular health is really important. So, and the health of blood vessels can be affected in people with PKD. And the reasons for having this are, partly because of some of these other what they call cardiovascular risk factors, so high blood pressure, high cholesterol, but there is a role of the PKD associated genes and their proteins, and the main protein is polycystin. And so there is an effect on the integrity of the lining of the blood vessels in the body. And so, arteries or blood vessels, I should say, around the body can be affected by polycystic kidney disease. So, for example, the artery that goes to the brain, which is called the internal carotid artery, can, and this is in late stage PKD, can be affected. Again, a little bit of, if you like, a narrowing in the arteries there. And, if you do have that, you need to detect that early because you can treat that with good blood pressure control, good cholesterol control to help reduce the chances of any, really dire consequences such as a stroke. Just to reiterate that there is a direct role of the PKD1 gene or PKD2 gene and polycystin, and how it can affect the integrity of the blood vessels. So I just want to highlight that this is, if you like, the blood vessel wall of someone who's got it's called an aneurysm, an intracranial aneurysm, and the lining of the wall is affected by a so you've got polycystin 1, which is affected, if you like, in the wall of the artery, which is affected by this aneurysm. And so the consequences of having polycystic kidney disease are that the integrity of the arteries in particular, and in this particular example, the intracranial aneurysms can be affected. So if we can go on to this, intracranial aneurysms are, as the word says, within the brain. There are different forms. They can be either saccular, which is like a little sort of sac, or it can be fusiform, so it's like a little sort of football, like that. And the prevalence, if you like, or how common it occurs in people with polycystic kidney disease, it is more common in people with polycystic kidney disease. However, you might be surprised to know that intracranial aneurysms are actually also present within the general population. In fact, 2.9% of people in the general population will have intracranial aneurysms. This compares to 12.9% in people with ADPKD. But if you have a positive family history of intracranial aneurysms, then that goes up to 17.1%. The mean age of presentation is in the 40s, and usually prior to starting what they call renal replacement therapy or dialysis or transplantation. So if we have, if intracranial aneurysms are so common, why is it that we don't see that much of a problem with it, or at least what we can, if we talk to colleagues or friends who've got PKD? Well, the risk of rupture is actually quite low in comparison to the frequency at which you have intracranial aneurysms. In fact, if you the technical number of the risk of rupture is 0.57 per 1,000 patient years. So essentially, it's like if you have 17 people who live to the age of 100, one of those people will have an intracranial aneurysm rupture. Now, is that a high number or a low number? Well, I think everyone will have a different perspective, but it is certainly something that we need to be very careful and wanting to, if you like, prevent if at all possible. Now, if someone does have a rupture of an intracranial aneurysm, then the symptom that you can get is what they call a thunderclap headache. So that's where you get a really sudden onset of pain in the head. The pain becomes much worse within a minute or two. It may be associated with nausea or vomiting. Maybe it could followed by seizures, and you may black out. So if this does happen, then you need to seek immediate medical attention and get a scan done. So the question then is, how do we try to detect intracranial aneurysms, and how do we treat them? So there is a role for screening for intracranial aneurysms. The whole thing, and I think it's very important to talk to your healthcare professional about whether you should or should not have screening for intracranial aneurysms. The CARI guidelines, which were released about 9 years ago and which are still relevant today, suggest that if you have a positive family history of someone with an intracranial aneurysm, then you should be, and you have polycystic kidney disease, then you should have a screening test for that. If you do not have a family history of intracranial aneurysms, then a discussion about the risks and benefits of having testing is really important. Now, for example, if you are in a job that is, if you like, a high risk of a problem, if you have intracranial aneurysms, such as if you're an airline pilot or a professional truck driver, then you may want to get screened for that as well. I think the bottom line is that if you do wish to be screened, generally, and this is what I do when I look after people with PKD, I'll generally offer them screening because I think it's often better to know than not to know. The testing is done with imaging. The imaging test can be either a magnetic resonance angiogram, which is called an MRI, MRI/MRA, or you can do a CT scan, and it's what they call a CT angiogram. Now, either test is good, and there are roles for either test in specific circumstances. Again, you should talk to your healthcare professional about that. If an intracranial aneurysm is detected, then referral to a neurosurgeon who has expertise in intracranial aneurysms is recommended. And the type of therapies that are done do include what they call endovascular coiling or microsurgery or open surgery. And I think the decision needs to be done by a surgeon who has expertise and experience in this. We'll go on to look at heart health challenges. Now, these are unfortunately common in people with polycystic kidney disease, and I'm going to list some of them here. And I think things like left ventricular hypertrophy refers to the thickening of the heart wall. That can occur in people who have high blood pressure. So I think treating the blood pressure will help reduce the risk of left ventricular hypertrophy. Valvular heart disease is where the valves, and particularly these valves here, what they call the mitral valve, can get a bit leaky. And when we do the initial assessment and ongoing assessments of people with PKD, we'll also check your heart. We'll actually listen to your heart with a stethoscope and listen to see if there's any murmurs or sounds that might represent a leaking valve. Now, if we are suspicious of any valvular heart disease, we'll do what they call an echocardiogram, which is like a little ultrasound of the heart to detect that. Atrial fibrillation can be detected by doing an ECG. Actually, just checking your pulse can also detect that. And then coronary artery disease and heart failure. So these are conditions where the arteries of the heart can be blocked or narrowed, can be detected by clinical assessment and are treatable for sure. Now, I see that my time is sort of running a little bit short, so I'm going to just go through this. Hopefully, so pregnancy and reproductive issues are a real challenge, and I think in polycystic kidney disease, the discussion regarding conception, particularly in people who have a genetic condition such as PKD, needs to be discussed really carefully with your healthcare professional. We know, and I do have the discussion a lot about the role of IVF, in vitro fertilization, and the role of testing for the genes for polycystic kidney disease through what they call pre-implantation genetic diagnosis. Now, this is a very it's a sensitive topic. It really needs a lot of discussion. Lots of people have different views, and so that discussion is really important. There are also, interestingly, with polycystic kidney disease, fertility is not such a big problem if you've got normal kidney function. However, as your kidney function does drop, then fertility can be reduced. And so that pregnancy planning, particularly if you've got very low level of kidney function and where you're heading towards dialysis and or transplantation, needs to be had with your healthcare professional. So when I see women who have ADPKD of childbearing age, it's really important to talk about the risks and benefits of contraception, especially with the estrogen-based contraceptives, and because of the role in increasing liver cyst size and also the role of increasing blood pressure. Medications, can be a problem if you become pregnant. So medications such as tolvaptan, such as some of the blood pressure tablets, shouldn't be used if you're actually actively planning to conceive. Once you become pregnant, and I just mentioned that there is a genetic counseling bit. It's really important to talk to both your nephrologist, but also your GP, and often we get a geneticist involved and the obstetrician who may want to discuss with you about the pros and cons of genetic testing. During a pregnancy, when pregnancy does proceed, there are things that we can do to try to make the pregnancy as healthy as possible and to reduce the risk of worsening high blood pressure and a condition called preeclampsia, which is a condition that is at much higher risk in women who have kidney disease. And so use of things like aspirin, dietary calcium intake, blood pressure control, and regular monitoring really has helped to improve the outcomes of pregnancy in women who've got polycystic kidney disease. After pregnancy and in the lactation phase, there's a need to modify medications to make sure that the kidney disease is as stable as possible, and then to restart therapies such as tolvaptan after breastfeeding is finished. I'll just touch on some of the symptoms of PKD. So fatigue is a really common symptom. It's more frequent and worse with progression of CKD. There are multiple causes. I did already touch about liver cysts and big livers being a cause of fatigue. Anemia is a very common cause, reduced kidney function, physical conditioning being lower. But even some of the medications can cause fatigue. So tolvaptan can cause increased urination, particularly at night time, so you can't sleep so well. Some people use pregabalin to help with neuropathic pain, but then that can also cause tiredness as well. But there are also other conditions that can be associated with as you get older. So, for example, sleep apnea can cause fatigue. So I think the strategy is always look for a cause of the fatigue. Don't just think, oh, there's nothing I can do about it. There's often something you can do about it. Also, that be careful about using supplements, especially over the counter, without talking to your healthcare professional first. I might just talk about pain as a symptom. It's a really common thing. There are multiple causes of pain in PKD. They might, because the cysts are big in the kidney. It might be because the cyst has bled. It might be because the cyst is infected. It could be because of a kidney stone. There are other causes related to PKD, and we've touched on hernias, on reflux, esophagitis, diverticular disease as causes. There may be unrelated causes, and back pain is something that I get asked all the time. And it's like, is this because of the polycystic kidneys? And sometimes it is, and sometimes it isn't. But it's good to have that evaluation. So how do you approach this problem of pain? You do try to investigate and treat for the underlying cause. There are some things that we can do for kidney cyst pain. Tolvaptan is potentially a way that has been shown in some research studies to reduce pain events. Kidney stones need to be treated, and there are targeted therapies to reduce the size of kidney stones. And general analgesia as well, with that avoiding, anti-inflammatories like ibuprofen or the related medications. So we did mention about kidney stones. These are relatively common, and they're mainly because of reduced urinary flow and abnormal kidney anatomy. You can see the little stone, well, actually, they're big stones, one on the right kidney and one on the left kidney. You can have multiple stones. They present with pain, urinary tract infections, blood in the urine. We look for an underlying cause. So you can do what they call a 24-hour urine collection and check for different the chemistry, so the sodium, the calcium, the uric acid, the citrate, the magnesium. So look for all those things. There are often things you can do to reduce kidney stones. So you can hydrate better, you can have less salt intake, you can have more citrus in the diet, like lemon and lime. A bit more magnesium sometimes helps. So all those things, are very helpful. Surgical intervention is sometimes needed for these stones as well. It's important to know that if you get a new transplant, the cysts aren't going to affect the new transplant, and therefore the risk of stones is, not so high with a normal kidney transplant. I'll mention some other manifestations of ADPKD. So eye health needs to be always looked at, not just because, it's important, but also there is an association of some of these conditions, retinal detachment and retinal artery vein occlusion with PKD. Again, it's a very rare association. So I think if you just get a routine eye check, those things will help to, detect anything like that early. And also controlling blood pressure, cholesterol will be very helpful in reducing the risk of those. There are also sort of other vascular changes that are very rare, pancreas and spleen cysts, which generally don't cause a problem with the function of those organs, bronchiectasis and pleural effusions of the lungs. Again, they don't generally cause a big problem. And so no specific screening for these sorts of abnormalities is needed. In the last maybe 5 minutes, I'll just talk about some of the psychosocial aspects of polycystic kidney disease. So I think it's really a challenging condition. I'm sure that you're all aware of that. And I'm not going to go through every point on this slide, but to note that because of the inherited nature of the polycystic kidney disease, there are sort of challenges that need to be addressed. There are physical stressors because of the nature of the disease, that you get big kidneys, a big liver. Um, it does impact the family. And so trying to work out how to approach these things. So, for example, how to find a kidney donor when you know that this is a genetic kidney condition is a big challenge. And so even things like finances, employment, insurance, all those things need to be um, handled. So mental health needs to be really specifically addressed. And so things like depression, anxiety, chronic pain, helplessness, all those things are just important to address. And I think between the nephrologist and the GP and other health professionals within the team, all these things can be managed. And I think that open communication, education, and having a multidisciplinary team approach um, really improves the chances that the mental health um, will be optimized. And so looking at, a holistic, if you like, point of view or viewpoint for PKD, there are the nutrition needs to be optimized, trying to avoid all the nasty things like smoking, too much alcohol, not too much caffeine, exercising well, strength training, and looking after yourself with mental health. They're all very, very important. So there is a checklist that I've put here, and I think Jess, I'll probably I'm sure the presentation will be available for those who want to have a look at it. Please have a look through this. This is sort of meant to be a checklist that if you're someone who's got PKD, or you're a carer or partner of someone with PKD, then you can ask these questions from your healthcare professional. And education is empowerment. You'll just know a lot better, and you'll be able to look after yourself much better. Because I think the landscape of Australia's health is really a bit of a minefield. If you're this person here and you're not trying to navigate all these different sort of challenges, trying to sort of work out your life, where you live, trying to make sure that you live a healthy life with good physical activity, not smoking and all that. But in the end, you might end up needing to go to your GP, you might need to go to community care, your pharmacy, and all that. But most people will end up in a specialized unit, like a hospital, and then trying to sort of navigate how you get all these medications funded. Where do you get the medications from? How do you get the tests? How much do the tests cost? It's all a bit of a minefield. So I think, it's not. You should ask lots of questions, and I think and I'll probably open myself up. I'll get lots of questions from my patients, and I think it's absolutely great because it means that in, information and education empowers you to make the right decisions. And so having that sort of good connection with a good GP as well as nephrologist and other healthcare professionals is really important. So, I've emphasized that self-management is just, a real key to improving your health outcomes. I just want to do a shout out that the Kari group, which I have a connection with as well, has been funded by PKD Australia to co-design knowledge translation tools. And so these are basically education materials to help consumers with polycystic kidney disease to know more about their condition and how to manage it. And so just a shout out to PKD Australia for funding that work. And I'm sure that'll be coming in the next, hopefully, not too far to actually help our community of people with PKD and their carers and family. And look, there is information everywhere. PKD Australia has a great sort of website. I had a look through it the other day, where they go through all the different things about PKD, such as the symptoms, signs, and also, how does it affect my health? And so please just have a look through that, and I'm sure that'll be very educational. These are some educate resources available. I've mentioned PKD Australia. Kidney Health Australia also has lots of resources. The CARI Guidelines has a web link to consumer-friendly information that I think will be of help. And KDIGO, which is the international guideline group, where I actually got a lot of these slides from, by the way, has some videos that you can look at, and also some PDFs that you can actually read as well for yourself. I think that's it. Thanks, Jess.
Incredible. Thank you so much. That was a lot of information to get through, but we are so grateful. You really covered such a broad range so succinctly. And I loved how you finished that saying, education is empowering. And I really hope that everyone here is feeling very empowered. So we will move into a Q&A. So I'll just get you to stop your screen share.
Yep.
And then so we can see your face enlarged. There we go.
Yeah. Cool.
And so everybody, please feel free to pop your questions in that Q&A box button. And I will just reiterate, as Vincent mentioned at the very start, that we at PKD Australia do have a lot of resources, and some of those topics that were quickly glossed over, particularly relating to like genetic screening or pregnancy or like your diet and lifestyle, we have webinars about those already. And I really encourage you to jump on our YouTube or just, dig through our Facebook page and have a look and listen to what is already out there. And then, of course, you feel free to email me or any of us as well if you have something that you really need help with. Your GP is always your first port of call, of course. But yes, I just like to reiterate that. So we have just a couple questions coming through. While people are writing their questions, Vincent, I wanted to ask you, which we like to ask all our researchers and presenters, how you actually got involved in researching and helping like with PKD.
Oh, yeah, thanks, Jess. Yeah, look, so I became a kidney specialist in 2005, and I did a PhD. Actually, it was a basic science PhD. So in the lab and sort of pipetting and all this sort of stuff. But then after that, I ended up doing some research, looking at sort of, I suppose, clinical trials and things. And guidelines, and then I got involved with CARI in about 2015, and then I met a lot of the people that I still know today, working on the PKD guideline for CARI, which was published about 9 years ago. And so since then, I've done a lot of work with guidelines, and also I've been very fortunate to collaborate with Gopi Rangan, who I think PKD Australia will know very well.
Very,
Who,
very loved.
yeah, very well I've done. And I was on the steering committee for the Prevent ADPKD trial, which some of you will know looked at the role of water intake in people with PKD, and found that, yeah, if you can drink plenty of water, but you don't have to drink like a ton of water to help you with your polycystic kidney disease. So drink plenty of water, 2 to 3 liters a day. Don't have to go crazy with water intake. And then I've done a few other things with Gopi and with Kari. So yeah, it's been great. Good journey,
Thank
and
you.
learning all the time from everyone.
Okay, we will get started on some of these questions. I had them in the QA and the chat. So, a question relating to dialysis, which we do have a webinar on as well, but maybe we can quickly answer the cost of dialysis, and does Medicare cover it? Do you know?
Yeah, yeah, good question. So I can only talk for people in Australia, which I think most of this audience should be from. So yeah, if you have Australian residency or citizenship, then dialysis is covered. It's covered by the public dollar. And that's whether you do the two types, so hemodialysis or peritoneal dialysis, and whether you do home dialysis, home hemodialysis, or what they call clinic or hospital hemodialysis. It's all completely covered, which is like
Awesome.
terrific. Yeah, yeah. And transplantation is completely covered. The private health system also does cover uh, dialysis, um, and you just have to have that. There's a certain level of private healthcare you need to cover it. But if you don't have private healthcare, I wouldn't stress too much because, yeah, the public hospitals will all cover it.
Okay, that's a great answer. Good to know. Thank you. We have a comment here, a question rather, that says, I was advised very early on by my treating renal physician that we don't look for brain aneurysms as they're too difficult to treat. Any comments as to that?
Okay, yeah, look, I think it does depend on obviously the situation, but as a general rule, I think everyone who's got polycystic kidney disease should be offered screening for PKD. It does the risk and the benefits. So when we're asking to do a test or if we're asking to do a treatment, there's always a good side and a bad side or upside and a downside. And it's the same with testing. And to illustrate that, if you do a test to check if you have an aneurysm, then the potential benefit is that you find something, find an aneurysm, and then you fix the aneurysm, and then it's all fixed. So that could be a potential good side. The potential downside is that you might find an aneurysm, but it's so small that you don't need to worry about it. But because you know about it, it worries you, and then you have to do repeated testing for it. And so even just doing that repeated testing can be, it's very stressful and worrying, and more importantly, may not lead to a better outcome. So I think it's really important to talk to your nephrologist about, or talk to your healthcare professional about it. Um, People have looked at studies to try to sort of tease out, is it better to test or not to test? And I think the general consensus is that if you have a positive family history of intracranial aneurysms, you should test. If you don't have a positive family history of intracranial aneurysms, then the decision is it's a sort of an open question and depends on different factors. I think the big picture out of the decision making is that and that we should be always doing, is that it has to be a shared decision. So it needs to
Mhm.
be something between um, the person with polycystic kidney disease and the healthcare professional.
Yeah. I'm hearing a lot about that, about just that importance of, yeah, having a good team around you and, yeah, sharing that decision. So it's not all on you.
Mm.
Okay, thank you. Um, Another question. I'm on Telvaptan and have been told to go off it as I'm dehydrated, even though I drink 2 liters of water every day. Do you know why this would be?
Okay, it's a quite specific question, but I have to say an important question too, because tolvaptan, by its very, so tolvaptan leads, tolvaptan blocks a hormone called vasopressin, and that hormone um, causes cysts to grow. So if you use tolvaptan, you will reduce the cyst growth. The problem is that there's this off-target effect. So it's not just targeting the cysts, but it's affecting what they call the concentrating mechanism within the kidney to make you pee more. So people on tolvaptan will pee more. Now they might pee, um, you know, during the day, but often they pee into the night as well. And it can be very troubling, and it can actually, like, you're peeing so much that you get dehydrated, so it can happen.
Mm.
So I think you know yeah, I would certainly, it's not, it would be something that could happen,
Yeah.
that you could get dehydrated from tolvaptan. Now the question is, how do you sort of manage that? Well, if you can, so people who are on tolvaptan will be thirsty and they will drink lots of water, and usually the drinking of water will compensate for that amount of fluid that you lose. But if you can't keep up with that fluid intake, then you can get dehydrated. Now, some people, they can't keep up with the fluid intake. And, I wouldn't sort of try to blame yourself because it does happen. And, I think tolvaptan, even though it is the one medication that we know that is targeted to reduce cyst growth in PKD, it is not a perfect drug. And so that's why we need more, we need alternative therapies. And so we're currently looking at alternative therapies. And I know that the PKD Australia has a webinar on Impede PKD, which is a trial looking at metformin, which is the drug that's used in diabetes, but actually we think it also reduces cyst growth.
Mm.
So we need to look at other therapies, evaluate them, and find alternatives to tolvaptan. Yeah.
Actually, just on that note, because I saw in one of your slides, there was the mention of joining registries so that people know about clinical trials that come up. And I just mention it because recently the Garvan Institute, and I want to get the name right, we featured it in a newsletter. But for those listening, the Garvan Institute has a genomics of rare disease registry, and they're encouraging people to put in an expression of interest to join the registry for the purpose of that, when a new clinical trial pops up, particularly regarding genetics, as it seems a lot of these clinical trials are moving towards more genetics focused, you'll be the first to know, and it'll make Australia a very attractive place for clinical trials to come, because not all of them are based in Australia. Impede is, but yes, so I just thought I would highlight the Garvin's registry there.
Yeah, I think Amali Maliaracci is probably the principal investigator for that one. She's a great researcher in genetics and PKD. Yeah.
He's also on our scientific advisory board.
Oh,
So
yeah, it's
yeah.
fun. Yeah.
Okay. Got time for a couple more questions. Can people with ADPKD have imaging that requires a dye injection?
Yeah, it's a great question. And I think um, it very much depends on your level of kidney function. So we use a test, which is the blood test. It's called eGFR, which I think a lot of you will have heard of. And I like to think of eGFR as like the percentage of kidney function that you have. So, people will normally have 100% kidney function. But as a kidney disease progresses, the eGFR, or the percentage of kidney function, will fall down to a level of, we would say less than 10% is when you need to really be, unfortunately, in kidney failure and needing a dialysis or transplantation. So where do you fit in when you looking at contrast? So if you have a GFR of greater than 30, then we would be generally fairly comfortable with using contrast. Again, there's a few factors that need to be in play, and talk to your health professional about that. Um, um, and if your EGFR is over 30, then it is generally safe to use contrast for a scan. Whereas if it's less than 30, then yeah, less safe. And the risk, for those who don't know, if you have contrast, so this is the dye that's used intravenously to light up and make the pictures on a CT scan look better. The contrast itself can temporarily, very rarely permanently, but mostly temporarily, harm the kidney function. So that's why some people go, well, we should be doing an MRI for screening for doing tests, and MRI can be done, but number one, it sometimes isn't as good, doesn't give as good a picture as the CT scan. And number two, it's expensive. And, if you're looking at doing an MRI of the kidney, generally people have to pay out of pocket for that. Whereas a
Mm.
CT scan, you don't have to. Well, yeah, sometimes you have to, like if you go to a private practice and they charge a gap, yeah. But yeah, I think it needs to be that sort of discuss it with your healthcare professional.
Thank you. Um, Another question. At what age should children be tested for inherited PKD?
Oh yeah, that's a great question. So Kari did release a guideline in our guidelines from nine years ago, and look, I think we'd still go with that. Is that at the age of well, you can, there's two age cutoffs. One is the age of 15, one is the age of 18. So generally say there's not really any point in screening for kids with polycystic kidney disease until they at least turn 15. Because the therapies that we use generally aren't going to be useful.
Mm.
Um, However, between 15 and 18, that's sort of the blurry range of consent versus no consent. So I generally say to my patients, I don't think screening until the age of 18 is um, like I would definitely talk to them about it once they turn 18 at the latest. Yeah. And then if the child who's now an adult, wants to talk about whether they should be tested or not, they should talk to their GP, or of course they can talk to a kidney, health professional. Um, there is some guidance in terms of if your child has some, I don't know, symptom like is going to the toilet more than they should be, or they're feeling unwell, well, you definitely should be checked. So, but if you're looking at someone like kids who are perfectly healthy, they don't look like they've got any symptoms, then generally the age of 18. There is also some work being done to sort of look at, well, should we be checking for blood pressure in kids to because blood pressure is a determinant of kidney health in the long term. And I think that's a challenging conversation if you don't yet have a diagnosis of polycystic kidney disease. So I think the bottom line is um, there's generally not a lot of like you wouldn't be offering tolvaptan to someone who's less than the age of 18. I think that's one of the things. You might offer blood pressure medication to someone who's, younger. Um, but it has to be a discussion that you would have with, yeah, your professionals. Mm.
Once again, a very important shared decision.
Yeah, definitely.
Okay. Well, there's so many questions. I'm trying to pick one more to answer with the time that we have. There's also a lot of thank yous for a great presentation. So,
Well, I can take another couple of questions.
um, okay, this one is not exactly a what would I say, science-based one. But as you probably, you see so many patients and just your opinion, what is the role of resilience in managing a chronic condition like PKD? And how do you cultivate it in yourself and family members?
Oh, yeah,
What
that is
takes
such a good
you have seen
question. Resilience is such a
on that one?
important, like it's a trait that, are you born with it or do you develop it? Um, I think that's, I have to say, the where possible, I think the supports are really so important, like family members or friends. Um, and I think that really helps a lot. Um,
Outsourcing for resilience sometimes when you
That's right. Yeah. I mean, if you're sort of, can't, you're having a bit of a down moment, then you've got someone else who can be a bit up for you, because yeah, it's, like they say, for so many things, it takes a village to, look after an individual. And that village is so important. And there's all these different people within that village that help. I think, what I find is a challenge to resilience is communication and the ability to get information about your condition from the healthcare professionals. So I think as a healthcare professional, that's one thing that I think I try to do
Mm,
to make sure that those communication lines are open in a sort of a way that makes it easily I suppose so. I make myself relatively easily accessible in any way. How can I say? Um,
good.
Not that I give my phone number out to everyone, but if people want to contact me through my surgery or through my rooms, then it's actually quite easy to do that. And I think that would be something that all our healthcare units should work on. I think navigation of the healthcare system, like I mentioned before, is such a key challenge. And I know there's research projects being done on how to improve navigation. If we can get that key piece together, I think that's really going to be important. I don't know, for those people who are from Western Sydney, we are looking at improving that engagement by both navigation programs. So the Children's Hospital Westmead, I've got one, and the other way is by using text message support programs for people with kidney failure on dialysis. And hopefully we're going to be looking at it for other groups of people with kidney health issues. So I think there are ways that we can do it as an individual, like myself or whoever, but then there are probably better ways that we can improve the system to make it a bit better in terms of being able to navigate the system.
Yes, it makes me excited for David Tunnicliffe's research project and what will come out.
Yeah.
Well, thank you. I think on that note, we'll finish there. There are more questions, but also mindful of the time. For those who again asked specifically diet-related questions, I really do encourage you to just jump on our most recent webinar with Dr. Kelly Lambert, as that was done just last month, and she has, updated the information to be relevant for 2025. So, because I did see there are a few questions relating to diet, but with that, thank you so much, Vincent. That was, like I said, a huge amount of information, but extremely helpful. I think you covered some very practical aspects there. And it's definitely a webinar that I feel people can go back and watch and get something new out of it each time. So on behalf of the board and just the team at PKD Australia, thank you for taking time out of your evening to share with us. And to everybody for attending, thank you. Thank you for your questions. Thank you for leaning in and listening. And we will be getting as many resources as we can to you via our website as well. And as always, don't hesitate to reach out by email for anything else. So everybody have a great night, and thank you again, Vincent.
Okay. Thanks, Jess. Thanks, everyone.